So good evening. Welcome everybody. As usual, thank you for joining us. Hopefully everybody got the email. If you're joining us online, hope you got the email that included the handouts for tonight's presentation. This shouldn't take too long, so hopefully I'll get you guys out of here in a timely manner so you can have the rest of your evening. Tonight we're going to talk about Medicare Part D, the prescription drug benefit of Medicare. I don't think I have any housekeeping, so we'll just go ahead and get started. So you already know who I'm with, the Area Agency on Aging through the Pikes Peak Area Council of Governments. I'm the coordinator for the SHIP program. I did want to mention that in the handouts that I included for tonight, I did include a survey. Because this is a grant-funded program, we do not charge for our services, and we do rely heavily on volunteer efforts. The Administration for Community Living, who oversees this program at the federal level, does like to do surveys. They like us to collect surveys so that they can see that we are doing what they're paying us to do. So we do appreciate if you guys would complete the survey and return it. They can be anonymous. For those who received it electronically, that document, you should be able to check the boxes and type in comments. And if you could save that and return it to me, I would greatly appreciate it. Don't have to put names on it or anything like that. But it does help go towards our continued funding to just show that our efforts are making a difference. All right. So to recap briefly for the last 2 weeks, in our first session, we talked about Medicare Part A and Medicare Part B, also known as Original Medicare, talked about costs, coverage, enrollment, all that kind of fun stuff. Last week, we talked about the insurance options that are available to anybody and everybody who gets enrolled in Medicare, the Medicare Advantage plans and Medicare supplements or Medigap coverage. And so this week, we are going to talk about the newest benefit of Medicare, Medicare Part D. D stands for drugs. It's the new prescription coverage for Medicare. Many people don't realize, but drug coverage did not exist through Medicare until 2006. Prior to that, people were on their own when it came to prescription coverage. But in 2006, it was enacted into law. It was honestly, I was still doing this back then. It was honestly very, very impressive how quickly the government decided to approve this benefit and implement it. 6 months. They created the whole search engine on the Medicare website. I mean, it was all very, very impressive at how quickly and efficiently and effectively it all was put together. But again, prior to that, people were on their own for drug costs. The prescription drug benefit as it stands now, you can get it in 2 ways, standalone by itself or as part of other coverage. No matter how you get it, prescription drug plans must include formularies, which is the list of what each plan covers, what drugs each plan covers, and they must cover a wide variety, including both generic and brand name drugs on those formulary lists. If you get a standalone Part D plan, you will pay an additional or are likely to pay an additional monthly premium for that coverage. Or if it is part of an Advantage plan, if you enroll in an Advantage plan, it's usually included at no extra cost. With Part D benefits, there are the possibility and the likelihood of deductibles, and there are going to be copays for the prescriptions that you need when you pick them up at the pharmacy. There is also, as we talked about for Medicare A and B financial assistance, there is also a financial assistance program available just for Part D coverage. And that is, of course, is going to be based on income and resources. So, do you need to have Part D? As with any and all things Medicare, it is optional. However, if you choose not to enroll in a Part D when you first become eligible, and you do not have other what they consider creditable coverage, meaning you have another source of drug coverage whose benefit is as good as or better than what Medicare offers, and you need to get that coverage 5 years down the road or 10 years down the road, you will pay more to do so because they're going to penalize you for not getting it when you first became eligible. If you already have other creditable drug coverage, for example, if you are a veteran and you can access the VA health system for your prescriptions, if you are a para-retiree or a civil service retiree, military retiree, or have any other source of creditable drug coverage, you do not need a Part D, and you would not have to worry about being penalized if you lost that other creditable source in the future and had to get a Part D for coverage. When you're looking at enrolling in a Part D, you do want to take into consideration, even if you have other creditable coverage, you may want to compare that coverage and the costs associated to get your prescriptions through that coverage to what your costs might be through a Medicare drug plan. So cost, as always, is going to be a primary factor when it comes to healthcare and prescription costs. You're going to want to take into consideration any premium you might have to pay for that prescription coverage with Medicare. And again, if you don't get it now, and I do talk to some people that they just don't take any drugs, they have no prescription needs. And it begs the question, well, why should I pay for something that I don't need to use? My answer has always been Medicare wants you to look at their coverage like you look at any other kind of insurance, whether it's car insurance, home insurance, health insurance. We don't buy it because we need it. We buy it for just in case. And it's the same kind of theory. And that's why they're not going to ever stop you from buying this coverage in the future if you don't get it when you first become eligible, but they are going to make you pay a little bit more for waiting. As with all things Medicare, there are specific enrollment periods that you need to worry about. Your initial enrollment period, which is that 7-month window to enroll in any and all of what we've talked about, surrounds your 65th birthday month. Medicare Part D benefits also have the annual open enrollment period, that October 15th through December 7th opportunity every year to look at what options are available for the next year. And then, as always, there are going to be opportunities that fall under the special enrollment. Again, special enrollment opportunities are typically going to be a result of involuntary loss of some type of coverage. So, waiting to enroll. If you remember from week 1, the Medicare Part B penalty, if you did not enroll in Part B when you first became eligible, you weren't actively employed with health coverage, you just didn't think you needed it at the time or you didn't want to pay for it, and you enrolled down the road, you had a 10% penalty for every year you delayed enrollment into Part B. For Part D purposes, D as in drug, the penalty is calculated at 1% for every month you delay enrollment into drug coverage. And that is basically because it's based on a calculation of a much lower premium. So it's still going to be based on the national average benchmark premium, which is the national average premium across the country of all plans, which for 2025 is determined to be $36.78. So if you had waited 5 years and it's this year that you're going to get drug coverage, didn't have any other coverage in the meantime, they would base that 5 times 12 months, 60%. That's 60? No. Yes. So they would base that every month that you went without, multiply that by the 36.78, whatever that comes out to would be tacked on top of a Part D monthly premium for whatever plan you enrolled in every month forever and ever and ever. Penalties never go away once you incur them, and they're tacked on every month forever. But it's going to be a much smaller amount because it's based on a much smaller premium, even though it sounds like a lot when you count up months like that. So again, my advice is always, please don't do that. Please don't incur the penalty because it never goes away and it adds up after a while. For people who may qualify for extra help in the future, say they don't enroll now for whatever reason, but their income and resources are low enough to qualify for assistance with the cost of Part D. Penalties are not applied because they qualify for the financial assistance. Part D is also subject to the means test, meaning if you have a high annual income, you may pay a higher monthly premium. Again, that higher amount is going to be tacked on top of the premium of whatever plan you choose to enroll in. So the income limits for individuals and joint filers, 106 or less, or 212 for joint filers or less, you pay no extra. But if you start going over $106 or $212 or 106,000 or $212,000 annual income, then you may start looking at paying higher Part D premiums. Again, that amount is going to be based on the most recent, most complete tax filing that Social Security can access, which is going to be most likely from, say, 2023, because we're just now filing 2024 taxes. So if in 2023 you had a pretty good income, you may be paying a higher Part D premium and a higher Part B premium when you first get onto Medicare. Again, Social Security does look at that that means test every year. So if the next year you've been retired for a year, your income is not over those amounts, they're not going to make you pay that higher premium the next year. So it will fluctuate as your income fluctuates. It's not like a one and you're done kind of thing and lasts forever. For anybody who's under that $106,000 or $212,000 annual income, you don't have to worry about the extra tacked onto your premium. Now, because Part D plans, this year we have 14 plans to choose from in Colorado for standalone just drug coverage Part D plans. And then however many plans include Part D as part of an Advantage plan. But those 14 standalone plans each have a different premium. They have different copays. They have a different list of drugs. But the likelihood of someone who gets on a standalone Part D plan staying in that same plan year after year after year is pretty slim, because these plans will also take advantage of that annual open enrollment period in October to make their changes. And that's why you're given an opportunity in the fall to make your changes, because you're going to want to see what these plans changes are going to be for the next year. And the plan that you've had this year may not be as good for you next year because of changes that they've made or changes that you've had to your prescription needs. That's the whole point of that enrollment period. So keep in mind that anybody who incurs a penalty or anybody who that IRMA applies to, that amount will stay the same for the IRMA, but it will just be tacked on to the difference in whatever premium you decide to pay for the next year. When it comes to the penalty, however, what you need to know is that that penalty amount is recalculated every year, because the national average Part D premium will change every year based on all of those changes the plans make. So will your penalty. It'll always be calculated at the same number of months, but that penalty is going to fluctuate based on every year that benchmark premium fluctuating. So all the more reason not to get a penalty, because that is literally just too much math for me. It's just too much. They have to make it that complicated. On the plus side, Medicare Part D prescription coverage had some very positive changes go into effect in 2025. Medicare Part D used to have like a 4-level series of coverages. There's the deductible level, then the initial level where you pay just copays, and then the donut hole that you may have heard about, where you go back and you pay higher amounts at the pharmacy. And then if you had really expensive drugs, you might have hit the catastrophic level where you pay 5% or less for your drugs until the end of the year. All of that has gone out the window, thankfully, because that was also a lot of math. So the most positive aspect of Part D coverage changes for starting in January 1st of 2025 is that all of that went out the window, and now the most anybody will pay out of their pocket in a calendar year for their prescriptions, regardless of what plan you have, is $2,000. So there's the drug benefit has been capped at a maximum $2,000 out of your pocket. Doesn't include the premiums, but it does include the deductible. That is huge for so many people. So it eliminated the donut hole. There is no more 4 levels of coverage to calculate. There's your deductible, and there's your $2,000 cap. If you hit the $2,000 cap, whether you hit that in April or May, or you hit that in December, once you hit that, you pay nothing for the rest of the year for any prescriptions through that plan. So for people who hit that cap in the first couple 3 months, the rest of the year is at no cost to them, except for their plan premium. The $35 insulin benefit, which went into effect in 2023, is still going to continue on. So many plans have voluntarily participated in that program where they offer at least one insulin in their formulary that is capped out at a maximum $35 copay per month. So that is continued. And Medicare, because of this $2,000 cap and the way it's going to be calculated, which is also a lot of math, they have created what they call a monthly payment plan, where someone can spread out that $2,000 amount over the course of 12 months, or however many months are left in the year when they decide they want to do that. Because for many people, if they have expensive brand name drugs, the deductible for Part D coverage this year is up to $590. And a lot of people would not be able to come up with $590 for a month's supply of their drug in January, no less. So that payment structure allows them to spread those costs over the course of 12 months, even though when their drugs are that expensive, they're going to hit that donut hole or that $2,000 cap in 3 or 4 or 5 months. Those first couple of months are going to be a hardship. So it allows them to spread that over a longer period of time. The way they calculate it is a little convoluted. And I did include a handout, I think, of how they do that. So be sure to take a look at that if you're interested. But it will be helpful for a lot of people. But again, once you hit that $2,000 out of pocket, zero out of your pocket for the rest of the year for any of your medications. Simple as that. It has made my job that much easier. And so for that reason alone, I appreciate it. But again, as I mentioned, other improvements that have come along recently to the Medicare drug coverage, the $35 max copay for some insulins. Medicare is still going to continue to be able to negotiate the pricing of a lot of the brand name drugs that are covered. As of this year, they were able to negotiate, I think, 15 drugs for a discounted lower cost to the government. That goes into effect next year. And then every year from here on out, they're going to be able to negotiate an additional 10 to 15. And I think in 2028, they're going to be able to go up to as much as 20 drugs, additional drugs for a reduced cost to the government. So hopefully, and those costs will be passed on to the consumer. Those savings will be passed on to the consumer. So thankfully, hopefully that doesn't get clawed back for any reason. But that is all going to be very helpful for people on Medicare because it's going to save money. And when it comes to the cost of drugs, anytime you can find a way to save money, the more power to us. So besides the cost savings, there are other requirements that Part D plans must meet. Every Part D plan, even if it's from the same company, and again, there are a handful of insurers that offer multiple plans. Every plan must cover at least 2 medications in every class of medication. For example, high cholesterol medications. Each plan has to cover at least 2. Heart medications, they have to cover at least 2. They can cover more than 2, but they have to cover a minimum of 2 in every class of medication. There are some classes of medication they must cover any and every drug available on the market. The 6 classes are listed here: the antidepressants, antipsychotics, anticonvulsants, antiretrovirals, immunosuppressants, and the antineoplastics. Those are the cancer drugs. Every plan must cover every drug in those 6 classes. They also can only cover drugs that have been approved by the FDA. I was very surprised to learn that there are many drugs that predate the FDA that are not considered approved yet by the FDA because the FDA never bothered to go back and approve them. So they have to be approved by the FDA, and they have to be approved and prescribed for their medically intended purpose. And when I say that, what I mean is the best example I can come up with is Viagra. Viagra was created for one purpose. It is now sometimes used and prescribed for another purpose, such as heart issues. All plans must cover drugs, including biologicals and insulins, and the supplies for injecting insulins, syringes and needles and such. And every plan must include both brand name and generic drugs on its formulary. Things that are not covered by Part D: anything that is covered under Medicare Part A or Part B. So if you have to go to your doctor's office to get an injection in your back for pain, that is not going to be a Part D drug. That is going to fall under Part B coverage because you had to go to a doctor's office to get that performed. Any drugs you take while you're inpatient in a hospital are going to fall under Part A and covered by Part A. If your doctor gives you a prescription, you have to take that to the pharmacy so the pharmacist fills it. That is what falls under Part D. Also does not cover anything considered over the counter or doesn't require a prescription. Even if it requires a prescription, if a drug is prescribed specifically to treat anorexia, fertility purposes, or for cosmetic only purposes, they're not going to be covered by Part D. Even if they require a prescription, if they are prescribed just to relieve cough and cold symptoms. Robitussin is a perfect example, not covered by Part D. And then most vitamin supplements, vitamin and mineral supplements are not going to be covered by Part D unless they're prescribed for a specific medical condition. So prenatal drugs, vitamins, for example, are a good example. Other than that, if your doctor says you need to have it and your plan covers it, it should be covered by Medicare through your Part D. So the way it works basically is Medicare created the Part D benefit. They manage it. They say how it works. They control every aspect of it. But like Advantage plans, they've allowed private insurers to come in and they contract with these insurers to actually act as the coverage, the actual provider of those drug benefits on Medicare's behalf. And that's why when you get a Part D plan, it is still your Part D benefit through Medicare, but it's a plan you pay for through a private insurer that is acting on Medicare's behalf. So when you enroll in a Part D plan, standalone plan that you pay a premium for through, say, Humana, that is still your Medicare Part D benefit. But that is also why Part D will never be indicated on your red, white, and blue card because it is contracted through a third party. So I will take a quick pause there. Are there any questions about any of that so far? No? All clear as mud. All right.
Robert,
yes.
There's a question in the chat.
Okay, so I do have a question in the chat. If I have employer group health insurance, which includes drug coverage or prescriptions, and I choose to delay enrollment in Part D, how will I know? Oh, that's a good point. How will I know if my current employer's group health insurance policy is credible enough not to incur penalties later for Part D? Everybody, regardless of how old you are, every year your employer is required to give you a letter that says if you have health benefits, whether or not those health benefits include creditable drug coverage for Medicare purposes. I've been getting those letters for years because that letter is required by law to be given to every employee who is covered under employer health insurance. So that letter from the employer that you get every year is going to say whether or not that employer health coverage is creditable. And as long as that employer coverage is creditable, there is no penalty down the road. Hopefully that makes sense. And hopefully you've seen those letters because we all should have gotten them for the last 15 years. And again, as long as you have what's considered creditable drug coverage, even after employment ends, if that creditable drug coverage continues through a retirement benefit of any sort, if you have VA access, all of those things are going to be considered creditable. And even in a retirement benefit scenario, they're still going to give you that annual letter every year that tells you whether or not the drug coverage that you're getting through them is still considered creditable. So hopefully that answers that question. And if you're not getting that letter, please ask your employer for it because you should have gotten it a couple of months ago. All right. I did mention a little bit ago that there is financial assistance available specifically for Part D purposes, referred to as low income subsidy or more commonly known as extra help. This financial assistance is applied through Social Security directly. So you do the application. They are the ones who are actually subsidizing the cost for Part D for people who qualify. I need to change the slide. I keep forgetting. There are no longer several levels of help. It's a one and done. Either you qualify or you don't based on whatever the highest income and asset level was. So prior to this year, there was multiple levels of extra help that provided multiple levels of assistance. Again, with the recent law changes, there's one extra help if you are within the highest level of what used to be the income levels and asset levels from previous times. That is now the only level. And if you qualify to get a Medicare Part D plan with no premium, no deductible, and reduced copays. Income and asset levels from here on out. Individual can have an income as high as $1,976 gross income per month. A couple $2,664 this year. So these asset and income levels are higher than for the assistance with the Medicare Part B premium. So more people should qualify for help with drug coverage than do for help with other Medicare costs. Asset limit is also higher. $17,600 for an individual, $35,130 for a couple. Those numbers do include a $20 added to it as a disregard and a $1,500 per person, basically a disregard to the asset limits. If you fall within those income and asset limits, you can qualify to get almost no cost for Part D coverage, for drug coverage. We do help with these applications. Again, they're applications submitted directly to Social Security. You can do them online. They take about 5 minutes to complete. They don't require any verification or documentation. So if anybody qualifies, we try and get them applied for right away. Social Security responds through the mail in about 3 weeks. The coverage, the assistance goes into effect right away. For those people who may not qualify for extra help, they may just be over those income or asset limits, but may still have a difficult time. Now, how patient assistance programs are going to be affected by this new $2,000 cap to drug coverage with Medicare, we don't know yet. They haven't really said anything. I think they've got too many other things to worry about right now. How it used to work is for those who didn't qualify for extra help and before the $2,000 max out of pocket with Part D, people may still have struggled to afford the cost of some of the more newer brand name drugs. There were other avenues we could look at for those brand name drugs to get assistance directly from the manufacturers of those drugs. And if someone didn't qualify for extra help but still struggled to pay their copays, we could go directly to the maker of, say, Eliquis or, one of those more expensive ones to see if they offered their own assistance program for people. And if people qualified, many times they could get that drug through that assistance at little or no cost for the rest of the year. I'm going to be curious to see how these patient assistance programs continue or not continue to help people with Part D now that there's that $2,000 cap. But hopefully they'll have some level of assistance still available because I know some people will still struggle. But these are the websites we tended to go to for looking for that patient assistance program from the manufacturers. So, things to take into consideration. Cost. Always at the top of the list. You're going to want to look at premiums. You're going to look at copays. You're going to look at deductibles. You could do that by calling all 14 plans, and those plans are listed in the back of the Medicare and You Colorado specific handbook, as are all of the Advantage plans. And you could just go through and call each plan and ask them if each plan covers each of your medications and what their copays are for that medication and what their premiums are, and if they have a deductible, and sit there and do all the math yourself to see which plan would save you the most money on your drugs. Or you could call a broker or agent and ask them if they would do that for you. Or you could do the most effective way of doing a search like that and going to the Medicare and You our Medicare.gov website. I mentioned in week 1 that you can go to Medicare.gov and create a personal account. Basically, they're just going to verify you are who you are, and they're going to recognize you by your Medicare number. There are advantages to having a personalized account on the Medicare website, and the website has a lot of functions that might be useful to you. It also has a electronic health records function. I know electronic health records is something that is a really good idea because it makes sure that every provider has that access to your records, regardless of what you're seeing that provider for, so they can all kind of work together instead of each provider just kind of having no idea what the other providers may be doing for you. But it's been hard to get off the ground for some reason. And I think a lot of that has to do with the technology. Nobody's willing to come up with a universal database for everybody to put that information in. So at this point, there are different types of electronic health records databases that you can allow your providers access to. Medicare.gov has one of them. But the Medicare.gov website also has basically a search engine like Google that allows you to put in all of your specific medications, including quantities, dosages. You can put in up to 5 pharmacy preferences in your area. It will take all of that information, compare it to all the plans available in your zip code, and the end result is it will list those plans in order of the plan that will save you the most money on those prescriptions at the top of the list to the plan that would cost you the most money on your prescriptions at the bottom of the list. To do that, go straight to the Medicare website. This is actually a screenshot of the homepage. From the homepage, you just click on the Find Health and Drug Plans button. If you've created an account, you can simply log in with your credentials, but you can use this search engine without logging in, which is what we do during open enrollment for people. We can do a generic search solely based on zip code, and it walks you through the same steps. The next page, it's going to ask you if you want to look at the drug costs specific to your drugs. You say yes. Then you start typing in all of your medications. That function has autofill. So once you start typing a couple of letters in the name of your medication, it tries to help you out and autofill. And then the next page, it asks you what dosage do you take, how many do you take a month. It gets all of that information, compares it, and then sorts it at the end of it all from least cost to most cost. It is literally the most effective way to do a search to determine what plan is going to save you the most money every year. This search engine is used obviously most prevalently during open enrollment when everybody's looking to see what's out there for the next year. But you can go in and play around with this search engine at any time. You can't accidentally enroll yourself in anything. So I use this all year long to help people see what their drug cost, what their estimates are. Their doctor's talking about putting them on a new drug. We can check to see if their current plan covers it and what the cost would be, those kinds of things. So I encourage people to go in there and play around with it to get a sense of how it works. We do help people during annual open enrollment period. We have hundreds of people come in here for that assistance, just so that we can help them make sure they interpreted the end results correctly and they know what they're doing. You can enroll in a drug plan or an advantage plan through this website as well, based on that end results search. When it lists all those plans, next to each plan, there's also an enroll button. It is the best way to enroll in a plan, whether it's a standalone Part D or an advantage plan with drug coverage. It is also the best way to change a plan. Because if you're changing from one plan to another during open enrollment, the way the Medicare rules are written, they're written to allow you one change per enrollment period. But if you disenroll from the plan you have and then try and enroll in a new plan, they consider that two moves or two changes. So you have to use enrolling into a new plan as an automatic disenrollment for the old plan. And this is the best, most effective way to do that, is to let them do it for you through the website. If anybody wants a walk through the website, give me a call. We're happy to walk you through it. We can do that through a Zoom call or whatever. Again, we're happy to just help you do it during open enrollment, but we're always available anytime for any questions or concerns or assistance with any of that. But it is really very, very effective. That is the system that I was most impressed with, that they came up with in such a short amount of time when Part D was created. And it has worked amazingly well since 2006. I've only ever seen it crash once, which is, to me, very, very impressive. Other resources, obviously the Medicare and You Handbook. Again, all of the plans are listed in the back of the Colorado specific book. Medicare website, and then of course you can call them anytime. You can call the 1-800 Medicare number 24 hours a day, 7 days a week, 365 days a year. And if you're worried about how long you're going to be on hold, call them at 11 o'clock at night before you go to bed. Call them at 2 o'clock in the morning when you get up to go pee. They're dying to talk to someone at 2 o'clock in the morning. You're going to get right through. And they're usually very, very helpful. And that's it for Part D. So any other questions? Get you guys out of here at a decent hour tonight. Another question online, just to clarify, you must be signed up for both A and B before you're allowed to enroll in Part D. No. Eligibility to enroll in a Medicare drug plan only requires enrollment into A and or B, not both. You have to have both to enroll in a Medigap. You have to have both to enroll in an Advantage plan. But for Part D, one or the other or both. Why that is, I'm not quite sure. Could be because there are people out there that don't take Part B because they use the VA health system, maybe. But that wouldn't even make sense because VA has creditable coverage. I don't know why it's not both, but A and or B for Part D eligibility. Yeah, I don't think I've ever gotten a clear explanation for that, honestly. Because I do ask a lot of questions about from CMS and Division of Insurance. Again, I'm always going to remind everybody about the SMP program, our sister program, Senior Medicare Patrol. that educates and empowers people to identify, report, and protect themselves and everyone around them from Medicare fraud, abuse, and errors. And I always like to say that's could be one of the more enjoyable aspects of volunteering for programs like this, because I like to send people on secret shopping expeditions to go listen to presentations that agents and brokers are putting out there in the community to make sure that they're doing their job appropriately. Misinformation is the worst thing that you can have when it comes to these kinds of benefits. And that's all I've got for you this week. Any other questions before I let you guys get out of here really, really early? Honestly, the change in the Part D coverage structure reduced this presentation by 10 minutes. So again, I'm happy about that. But yeah, as always, if you have questions, don't hesitate to ask. You can email me at the email indicated, Senior Insurer Help. You can always call us. And we're always happy to talk to you on the phone or schedule an appointment for you to come in or online. Next week, we're going to, our last week is also going to be short and sweet. Next week, we will talk about Medicare and coordination with other insurance options, such as military retirees, civil service, public service retirees, private retirees, Medicaid, those kinds of things. But that usually doesn't take very long, so it'll be a short session next week as well. And if there's no other questions, I will let you guys have the rest of your evening. As always, I greatly appreciate you guys attending and your interest in learning everything that you need to know and never wanted to know about Medicare. And just remind you, we're always available if you guys have questions.